Can everybody hear me? All right. Well, thank you for the opportunity to present something I'm super excited about and to follow HIV Alliance, which, as you'll hear, is a great partner in the Oregon Hope Study. And I want to say from the get-go that I've kind of modeled my slides after the Chime-In study to create sort of an urban-rural contrast. Okay, so the partners for the Oregon Hope Initiative are OHSU and the Oregon Health Authority, who are really driving this. HIV Alliance is doing most of our peer outreach, currently of our peer outreach, and then Health Insight is helping with some data as well as OSU and UW. The Oregon Hope Study is part of the National Rural Opioids Initiative that selected 8 high-needs states around the country. We're the only one west of the Mississippi for targeting overdose prevention interventions and expansion of Hep C testing and treatment and an array of harm reduction in high-needs rural counties in the U.S. In Oregon, we specifically targeted 8 of the highest needs counties. These are some of the hot spots for Hep C transmission as well as opioid overdose, in some cases having rates that even exceed the Portland metro area. For our pilot, we chose Douglas and rural parts of Lane County with a plan starting next fall to expand up and down the coast counties and down to Josephine. The basic design is a multifactorial design that's simultaneously targeting communities by forming community action teams, partnering with some of the existing overdose initiatives that are out there, as well as providing provider training. We're doing buprenorphine waiver trainings, an addiction medicine echo. We're hoping to expand a hepatitis C echo in the very near future, and partnering with the AATC for provider education. And then at the patient level, we're doing peer care coordination in these rural areas that's run through HIV Alliance. All of the participants we encounter are getting rapid Hep C and HIV and syphilis testing. And then the peers attempt to link the people to treatment services. And all of this is increasing Hep C and HIV testing in these areas, as well as access to treatment. We're recruiting participants in these rural counties through respondent-driven sampling, similar to the Chime-In study, a similar model. With inclusion of anyone who reports injection drug use in the past 30 days, either opioids or methamphetamines, or recreational prescription opioid use that's non-injection in the past 30 days. And they live in the study area, over 18 or over, English-speaking, and consent to prospective phlebotomy and storage of their blood for future studies. So far, our pilot has identified 101 participants in rural parts of Lane and Douglas counties. About half are male, the majority are white race ethnicity, 31% are under 30. And this is just shocking to me, but 70% of these folks are homeless or marginally housed. Over half have been incarcerated in the last 6 months. This is an extremely vulnerable, extremely high needs population right under our noses in our rural counties. About half report injecting heroin in the last 30 days, and 75% inject meth in the last 30 days. Remember that when I talk about drug of choice. Most everyone has experienced an overdose or witnessed an overdose. 72% have witnessed an overdose, and 43% have ever overdosed. Only 20% currently have naloxone, which is a little bit lower than what you'll see in the urban respondent-driven sampling. We're doing our Hep C and rapid testing. 44% are negative, fortunately, but 56% either report previous positive and test positive with rapid testing, or are newly diagnosed Hep C positive. 0 of these 101 participants have ever reported any past Hep C treatment. Again, this will be very different from what you see from the Metro data. Most participants report daily injection, and I just want to hone in on drug of preference. 41% of those with Hep C, it's comparable across the boards. The new Hep C diagnoses are slightly higher rates of heroin use. But drug of choice, actually about half in these groups are methamphetamines, even though that 75% of the sample is reporting past 30-day meth use. So even the patients with predominant preference for heroin are doing a tremendous amount of methamphetamines. I think we need to address both simultaneously with our interventions. Nearly half of participants have shared needles in the last 30 days. And again, this may be a little bit different from what you see in the urban settings. I appreciated Aaron's data. I don't think the message is quite reaching the rural areas, or rather, the resources to deal with that information is not reaching these rural areas. In terms of where people are getting their syringes, about a third of the Hep C negative are getting from syringe exchange, with a higher proportion of those who know they're Hep C positive and those who are newly diagnosed positive. HIV testing rates are fairly good for ever testing, not in the past year. I don't have that data to present right now. But almost everyone with a previous diagnosis of Hep C has been tested, with fewer in the negative and newly diagnosed category. And then you saw from Dr. Thomas's slides the data on hospitalization. And look at 5% of the HCV negative, up to 17% of the new Hep C reactive patients have ever been hospitalized for serious infection purposes. And then access to treatment. We asked participants in the last 6 months how much access to care they've had. Only a minority of patients actually have access to primary care. This is, it says private doctor, but the intent of the question was any primary care treatment, and it's less than a third in all groups. In terms of ever receiving any addiction treatment, it's a little higher, 38% in the Hep C negative, 47% in the newly diagnosed group. And then about a quarter of the Hep C folks and previously positive folks have tried to get addiction treatment in the past and been unable to. That number is lower for the newly diagnosed folks, but these are very small preliminary numbers. If I have, excuse me. Some of the major challenges are really transportation in these areas. I spent yesterday driving around very, very small unnamed towns outside of Roseburg with the peers, and it's remarkable. I mean, this is all Douglas County, and we were spending a half hour, 35 minutes to go from place to place. You just can't do this work without transportation. There are almost no bridges currently to buprenorphine treatment in these areas, and that's really our focus for this next year, is getting more treatment access. For example, one small town that has a primary care doctor that visits a half day once a week. I want to connect with that person with buprenorphine. capacity. Lack of Hep C treatment. Nobody has Hep C treatment. So our talk of Hep C treatment really has to be workforce talk in these areas. And then lack of telephone contact to contact folks. And then our future directions are really to address these through expansion of Hep C echo in particular, and MAT echo that we'll be doing more of in the next year. More buprenorphine waiver trainings, a cross-cutting Oregon Hope curriculum in partnership with AETC and OHA. And then sustainability. I mean, one of my questions for the last presenters is, you know, we're having a lot of federal funds pour into these areas for these issues, and we can't purchase syringes or needles with those funds. How can we as a group advocate for this? I don't have any great answers, maybe the state budget, but I think we really as a group need to tackle this direct funding of syringes and needles. And then advancing peer support services as well is another huge goal. Unfortunately, H.R. 6, the Support Act federally, really highlights the use of peers for substance use disorder treatment. But we need to figure out how that's going to filter into state policies and allocation. How am I doing on time, Jude?
We're a little bit behind, but you're doing great.
Okay. Should I talk about the peers? Okay. Thank you. It was a leading question. I was hoping for this. Okay. I'm so excited. You saw in our multi-level intervention, the patient intervention, and I just really want to highlight the great work that's being done by the peers at HIV Alliance. These are folks with lived experience with substance use disorder and recovery. They conduct extensive community and syringe exchange program outreach at some of the sites that you were hearing about in the last presentation. And really, they're building relationships and trust. That is their number one job. Because you go into some of these places, and it's beyond stigma. It's really confidentiality and privacy. You know, my neighbors in the next trailer over cannot see a van coming in with a sign that says syringe exchange on it, right? And so they're very incognito, driving in a low-profile way, and knocking on doors really is making friends. They have harm reduction gift bags. They offer naloxone rescue kits, a syringe exchange and needle box, and rapid Hep C and HIV encephalitis testing on the spot, as well as housing assistance and facilitation of getting people into care. So special shout out and thanks to Joanna and Larry, who are just doing amazing work that I personally could not do. 64% of the participants in Oregon Hope have accepted peer services. These are very preliminary numbers. The numbers have grown quite a bit since the slide. But among the people who accept it, 66% are being offered substance use service engagement. Really, most of the work is focusing on daily living, you know, connecting with local food resources. One of the clients we were interacting with was hoping for help getting presents for his kids for Christmas, this sort of thing, as well as goal setting and legal issues, and importantly, Medicaid insurance applications. Many of these people, almost all of them are outside the healthcare system, and many are uninsured still, not having applied for Medicaid. And then a lot of transportation. That's the other major service delivery. So far, these numbers are very small, very preliminary. This is an uncontrolled intervention currently. But 20% of the people that they've engaged with have so far connected with substance use disorder treatment services for at least their first appointment. 70% of those are actually initiating methadone, and because there's just less buprenorphine available, that's the second. And I'll stop there.